So questions, comments? Why don't I start with you, Carrie, with any online? There we go.
So we have one from online, and it's, do you know of any examples of the types of written agreements you referred to that could be used as a model?
It's a good question. No one's shared one with us, but that's the type of thing that you could post that in the Ontario, the OHT Community of Practice on the RISE website, and then I would encourage folks to share. The nice thing about this model is you're not competing. Ideally, every community across the province will eventually be covered by an Ontario Health team. So to me, there's all the incentive to share and no disincentive to share. So if folks are aware of an example of that kind of an agreement, please share it. And if not, in the short run, just post it on the Community of Practice and hopefully someone else will respond. Questions from folks in the room? Questions, comments, observations? Areas that you're working on that you think your team is perhaps further ahead and you'd be willing to share those experiences to for other people? Yep.
I was at an Ontario Health Team meeting in Northern Ontario, and one of the comments was, I think you pointed out, what's 1 year deadline dates? You know, we're doing full application, but they wanted to scope it down small enough so they can move the needle. So what's considered 1 year? Like, when's the start time, I guess?
So my understanding is that the start time is from whenever you're approved to start. So let's say you submit the full application, and let's say you find out on December 7th that you've been invited to the next stage, then the 1 year starts from whenever you're given the go-ahead. So it's not tied to a fiscal year. It's tied from whenever you get the check mark by your team's name to say go for it. Questions, comments? Most of the folks in the room, I think, are from Sudbury, but we have a lot of folks on WebEx from across the north and from some areas a bit further south. So feel free to weigh in on things that are unique to your communities that you think might be common across different parts of Ontario. Yep.
I have a question in regards to the October 9th timeline.
Yeah.
So this is a lot of information and new information that's coming forward last week and now this week and so forth.
Yep.
So my question is, what happens if we can't meet that October 9th deadline, but certainly are still very interested in moving forward?
Yeah. So, I mean, like you, I pay attention to everything that's posted on the ministry website. In their Q&A, what I understood when someone posed that question, the answer was, if you really feel you can't meet the October 9th deadline, contact your contact person, and then you can talk to them about what might be an appropriate new deadline. I think the challenge where the ministry will just be trying to balance things will be they're hoping to send these out to external reviewers. So if it's a little bit late, then you could probably be assessed as part of the same batch. If it's going to be a lot later, then that's fine. It just would probably be considered in a future batch. So this is a rolling process. It's just that the ministry is trying to line up many groups at the same time to go through processes that are kind of labor intensive in terms of review. But if you don't feel you're ready, it might be better to just take the time and get it right. But at the same time, everybody's in the same boat of trying to do something very complex. We're trying to really transform the system to better meet the needs of patients. That's not easy. And as you pointed out, resources keep coming available, like in this week or next week, you'll get your more detailed data package. You're just hearing from RISE today. So, we know that it's difficult, but everybody is in the same boat. So see if you can make October 9th. If you feel like you need a big chunk of more time, then talk to your ministry contact.
Okay, that's great. Thank you. And again, we really do appreciate all the information that is coming forward. So keep sending it, please.
Right. Super. Other questions, comments? Carrie, anything else coming in online? No? Okay. All those people online and no questions or comments. I always tell my students I'm very comfortable with silence, so I'm going to stand here for a while because it's such an opportunity to hear from you about what your needs are, to hear how we can help, to hear how other people can help. So can I jump to you?
Yes, thank you. I do have a comment knowing that the ministry is listening.
Yep.
So I think that as data and data packages are shared,
Yeah.
people are or teams become very caught off guard
Yes.
by the attributed population
Yes. Absolutely.
versus being asked to define your own geography.
Yep.
So I guess a bit of feedback for the ministry, knowing they're listening, is that on their own materials,
Yeah.
like the webpage, it says, you know, the standard pitch is a defined geographic population. And so there's a constant tension and contradiction between the methodology for attribution versus defined geography. And it does spur a lot of sidebar conversations and emails. And so if the ministry could just sort of align their language and be sort of clear on that, that would be probably helpful too, because we hear it also when they do introductions to webinars, define geographic population, and then you get further through and it's not so.
Yep.
So just a bit of helpful feedback, hopefully, for the ministry.
Yeah. Absolutely. Yep. So, I think that we're all learning our way forward, and, the ministry is on this learning journey with us, and to their credit, they're leaving huge amounts of flexibility up to local communities. So that creates tremendous opportunities, but they're always having to, at each step of the process, try to get the right material to you in time, and they're doing it across so many different teams that it takes time. So just to get out the full data package, I believe all this week and all next week, the data packages are going out and the one-on-one conversations are happening. So it's labor intensive, but point taken. But the other thing is that, and we've seen many teams get bogged down in the details of the attributed population. I guess my advice to folks, and remember, I don't speak for the ministry, I speak for myself and my colleagues at RISE, that we think it's probably helpful to, when you get the map, stand back and say, we said it was this geographic area. Now we're seeing referral and utilization patterns that are slightly different. Are we open to a model that would allow us to cover something much closer to that pattern? And if so, which, if any, partners need to be at the table? That's the big question in the immediate short term. The second big question is, you don't have a good handle on who these people are that are coming from outside the region, or which people live in your region who are going out. If you look at just the people that are rostered in your community, now this is on average, so Sudbury might be different from other communities, but on average about 82% of people are attributed based on rostering. So if you focus initially on that, that's going to get you a big chunk of people. And remember, year one is about starting to do this stuff, which is different from how we've done in the past. It's segmenting the populations, it's in-reach and outreach services. Year one is about trying it on for size and doing it in ways that you can document and then scale in future years, while paying attention to trying to work in areas where you can move the needle. Because obviously at the end of year one, we all want to be able to celebrate some successes, even though a lot of year one is about building the foundation for even more dramatic moving of the needle in future years. So always at each step, even though there might be some delays, in this case with data, when you get new information, just do a quick check-in. How do we focus on the big things that matter? And for attributed population, the two big things to me are, do we need to think about a different kind of boundary and therefore different partners, and how can we zero in on a group of people who we kind of understand initially for our year one pilot, recognizing that things will change over year one and they'll certainly change for year two. Yep, question? Yes. Oh, I don't know if others can. I don't see the light. It should turn red when it's on. If not, can you? Oh, there we go.
Okay.
Yep.
So I just want to clarify, because I think it's paraphrasing what you just said.
Uh-huh.
Year one is about looking at a very specific population. It's that we can measure in alignment with the quadruple aims. It'll be a very measurable, defined population. So although our group here consists of many different sectors and participants within each of those sectors, the first year population may not include perhaps their clientele or their patients. in year one only. You're looking to see year one, to see something that we can clearly measure, identify, align with the quadruple aims, then use it as our model for future growth in year 2, 3, 4, and 5, right?
Yep, I'd
So I
say
think that's what you
accurate.
just said. I just wanted to,
Yep.
I wanted to say it in my words so that I knew it in my head. That's it.
Yep. So let me give you some concrete examples. So I know a team that has picked 3 year 1 priority populations: older adults with multiple complex conditions, adults with mental health and substance use problems, and children with mental health challenges. So those are their 3 groups. Now that they know what their attributed population is, they're doing an initial stand back and they're saying, okay, do we need to adjust our partners? Because it turns out that we're actually drawing a lot of people from neighboring communities that weren't part of our initial group. And then simultaneously, they're saying to themselves, okay, if we want to be able to move the needle, are those the right 3 groups? Because now's a good chance just to stand back. We can, the ministry signaled they're open to you switching out your year 1 priority population. But once they've changed them, when they get to that first step of population health management of segmenting them, they're trying to zero in then on the population segments where the needle could best move. So if I look at, let's say, adults with multiple complex conditions, they might zero in on adults who are socially isolated who live with multiple complex conditions, or frail elderly people who live with multiple complex conditions, and zero in on those groups. And then to your very specific question, it could well be that there are partners sitting around the table who actually aren't involved in those population segments, and that's okay for year 1.
Right, so I'm suggesting that perhaps the population that we identified in our self-assessment was much too broad, and that we need to more clearly define individuals, a specific section of the health system. There are people that use certain services in order to measure that in alignment with that we can use the metrics of and align with the quadruple aim, right? You're saying that we don't use a broad broad population, clearly define.
I think you want to come up with a number of population segments in people for whom the metrics are currently poor,
Yeah.
and where you feel like if you really designed in-reach, outreach services, and care pathways for them, you could move the needle.
So you want us to identify populations that have the metrics are currently not necessarily.
Well, remember that, the ministry you're going to get another whack of more detailed data this week or next week. So remember that the ministry is now giving you this more population-based data, because many organizations currently just have data relevant to their group. Now you're going to start to get the population-based data. So now's the time to say, okay, we thought we were focused on population X. Maybe we need to adjust that. But even if we stay with X, what is X1, X5, and X7,
Yes,
the
okay.
population segments where we can move the needle, the ones where the metrics are currently poor, and we feel like it's feasible for our group to put in place the right services and so on that will move those metrics.
Okay.
Does that make sense?
Yes, absolutely.
Okay. Carrie, no, everyone's so quiet online. Folks online, even though you're not here, please, and you just have to put it in the chat box, and Carrie will read it out for you. She won't attribute it to you. Any other questions for the folks that are in the room? Yes, yeah.
This is a question more out of interest, I guess. I'm still on the fire hose stage.
Sorry, say that again?
I'm still in the fire hose stage.
Okay,
of
yes,
trying
absolutely.
to
Yep.
just
We
even
all
digest
feel
what's
like
on
that.
Rise. I'm wondering from the perspective of you and your colleagues, whether or not you're seeing or pulling a lot of evidence from health economists, and if so, where? I mean, are you just seeing that in the funding and incentive structure, or are there resources embedded in your briefs that are pulling from that?
Yeah, I mean, we don't distinguish, we don't really care whether you're a card-carrying health economist or something else. We just care about, are you producing insights that are relevant to Ontario health teams at this time? If you specifically want, the more economic evaluation-y type stuff, then when you go to the All Resources webpage, if you were to click on the far right-hand side, browse results, that's picking up both systematic reviews and economic evaluations. But there's a lot of economic thinking that is embedded in some of these other RISE briefs. It might not, when you read it, it might not say this is the health economics piece, but it's embedded in the thinking for sure.
Thank you.
Yep. Other questions or comments? So I know October 9th, it seems far away, it also seems close. But remember, all teams are in the same boat. And what you're really trying to do is set yourself up well for success for year one. And no one's going to have solved everything by the end of year one. This is incremental. And you're trying to learn and improve as you go. And if you have found ways to do things that you think are getting traction, one of the things we're hoping to do through RISE is give you the opportunity to share those because other folks can probably learn from them and vice versa. Yep.
So when you look at the information from the OHT, they talk about relationships and
Yep.
working together.
Yep.
And I didn't see a lot of resources on that. And so bringing all these organizations together has been a bit of a challenge, I would say, just because not everybody knows everybody or has good working relationships. And so are there going to be resources that talk about this, or has other OHTs looked at this in the past?
Well, I think that if I go back to the leadership infrastructure and work plans, the documentation for that RISE brief came out of work that was done by one local health integration network working with 5 teams. Not all of them made it through to being invited to full application. Some are currently in development, but some of what we called here the leadership infrastructure and some of what appears in the work plans is about trying to noodle through how do you do that. For the collaborative governance, that's largely what this is about. So if you read that RISE brief, you'll see there's talk about it could be helpful to sometimes bring the board chairs and the EDs together for processes. There could be times where you want all the boards together. So I think there's a lot of process stuff that would help. But right now, it's alluded to at a high level. It's kind of like a list of things you might want to think about, but there is likely to be part of the central program of supports that specifically focuses on leadership, governance, and accountability, and is likely to delve into a lot more detail, very practical processes that would help. So I'd say, as of now, it's superficial listings of things you might want to do, but I am pretty confident that we'll have partners around the table that can provide far more nuanced, in-depth resources for you on that exact point.
Thank you.
Yeah, Carrie.
It's not a question, it's actually a comment. It's one of the, so the Toronto East Ontario Health Team shared last week on the community practice a kind of community and partner engagement checklist, which goes through a very nice kind of step-by-step process of how you would go about this and is a very nice complement to the RISE brief. So that might also be one resource that could help to address your question.
And that was posted in the OHT community practice?
It's posted
Great.
in the community, and I can also send it to...
Super, okay. And then one of the things that we're hoping to do, the RISE briefs also aren't kind of locked in. Like our intent is to update them periodically. So when we find resources like that, we'll likely add them to the RISE brief. And then what we're trying to figure out is how do we alert the community quickly to say, hey, we've added 3 new paragraphs to this RISE brief, so you know that things are changing, but it's a helpful reminder. So certainly our newsletter will flag when things have changed, but we know you're moving so fast that we need a more efficient mechanism of showing you when things have been updated. Yep, Carrie?
Sorry, I now have questions. So the first question is, will there be any consulting dollars for primary care physicians that want to be involved with leading?
So my understanding is that there are no new resources available to help teams. In the RISE brief on primary care leadership and engagement, we specifically say that teams are almost certainly going to have to deal with this challenge about under what terms would they remunerate primary care providers' time. time if they invest a lot of time into a leadership role. So we flag the issue. It's likely to be team specific, but my understanding is there are no resources available to help teams. You have to, at this stage, work with your existing budget, but we know that for some primary care providers, this is a challenge. So I wish I had a better answer. It's just the reality that for the time being, this is all being done with available resources, but we know that there are going to have to be conversations about whether and how individual teams can remunerate primary care docs for their times if they take on a big leadership role. So let's, we have up to 15 more minutes, but if there are no other questions, what we might do is I'll just give the folks on WebEx one last chance to weigh in with questions, comments. Then what we might do is just close off the WebEx session, and then for the folks who've made the trip here to join us today, we'll then just have a quick, if it's okay, quick go-around just to get a feel for which teams are represented and see if you want to have a side conversation quickly. It's just a chance to get to know one another on a more personal level. So last call for folks on WebEx. Any questions or comments for anyone online? No comments? Okay, so thanks very much, folks who joined us remotely. We're grateful to you for plugging in, and we know that, Sudbury, the north is huge, and obviously it's not possible for us to get to every community, but we are hoping to mix and match in future to be in different communities over time. So hopefully one of these sessions in future will be in one of your communities, but thank you for joining us remotely. So we'll close off the WebEx session. Are we closed off? Sorry? Oh, we're just going to keep it open, okay, but we'll let folks leave. So what I thought might be just helpful is just to quickly go around the room and just get a feel for who's in the room. I think most people are from the local team, but if you're comfortable just introducing yourself, could we start at the back corner?
Sure, it's Marion Quigley with Canadian Mental Health Association, Sudbury, Manitoulin.
Great.
Don't do that. Denis Constantino, Centre de santé communautaire du Grand Sudbury, so Francophone CHC.
Super.
Jennifer Clemma, Sudbury District Nurse Practitioner Clinics.
Super.
Amanda Rainville, Caperl Nurse Practitioner-led clinic.
Super.
Deanna Chisholm-Tulio, March Times Canada.
Joanne Polkovitz, St. Joseph's Health Centre of Sudbury.
Kim Platt, St. Joseph's Sudbury.
Max Lidke, Health Sciences North.
Christine Barbeau, Northeast Lynn, Home and Community Care.
Great.
Stéphanie Leclerc, Société Alzheimer's Society, Sudbury, Manitoulin, North Bay, and Districts.
Kelly Zinger, I'm representing the Northeast Regional Home and Community Care Network.
Super.
James Foreman, Northeast Lynn, Project Manager.
Excellent.
Deb Shemansky, Onwood, and we're all four, so North Bay St. Mary's.
Wow. Okay. Super. Julie, Diana.
Adam Day, Northeast Local Health Integration Network.
Super. Excellent. Super. So now that it's just us in the room, any other questions or comments? Many of you are involved, it sounds like, in the Sudbury team, but others who play a much broader regional role are probably involved in other teams. Like, are you involved in multiple teams, given your huge catchments? So North Bay. Fantastic. In the next round. Yep. Okay. Okay. Thanks. Did you want to weigh in? Yeah. And are you involved in multiple teams so far? Okay. Okay. Absolutely. Great. So any other questions or comments now that we don't have all kinds of people listening in online, including the ministry folks? Yes. Yes, absolutely. Brutal. Yes. Yep. Yep. Absolutely. Yep.
Is that now they're at this pause for a minute, I think.
Yep.
Because if they start fighting, because they are just setting some deadlines.
Yep.
That would be my only thing, like the data, probably, nice for you, or they may want to do another session data.
Yep. I think, yeah, I mean, my advice would just be the moment that you get that last data slice, and especially the map, just have that quick check-in about, do we talk about our population in a way that's different? And then, you know, you don't have to have everything solved now, but you have to be able to speak to the strengths and understanding you have. But if there are areas like, boy, you know, there's this attributed population piece that we haven't quite worked out, but that's going to be part of our implementation, and we're going to work on it between the October 9th deadline and whenever we hear to keep up the momentum, just flag that. That would be my advice. Yep.
So just for the members in the room, recall last Friday you would have got an email from me. It includes a comment that the ministry is looking to book a walkthrough of this full package. So we will have an opportunity to get a crosswalk of the full data package, and by the end of day today, I'm looking for any members who absolutely feel they need to be on that call to let me know.
Super. And my understanding, correct me if I'm wrong, that they're trying to book those between the 19th today and the 30th?
Yeah, we'll be booking ours next week.
Super.
Yeah.